So post-operative complications are common. They're a major cause of morbidity and sometimes mortality. The impact to the patient as an individual is terrible. The impact to the system is just as bad, because people who get complications stay in hospital longer. They require a bed for longer, which means that we're doing fewer procedures, fewer surgeries, which means other people are queued at home and they're not able to access care. And it means that care costs more. So nobody's really happy when there's a complication. So if we can avoid them, even if we can only take off 10%, 20%, whatever, then I think we should do that, because it's an all-round benefit to every part of the system, from the individual who avoids the complication, their family, the clinical staff, the bed use, the funder, the taxpayer, everybody wins. So the opportunity was that we could actually see the problem, we could see the consequence, and we could imagine that interventions would make a difference. There was some evidence that small individual interventions did make a difference. Nobody had actually looked at whether a global, holistic sort of bundling up of all the sensible interventions would make a difference. We also had the opportunity to look at digital tools, and at the time, I think it was probably in this very room some time back, I sat near Ken and he was talking about they've got this great tool that can help people in that perioperative period just getting ready to come in for elective surgery. And I'm going, oh, why stop there? We can go right back here. So we started doing digital colonoscopy, triage and preparation. And then we thought, oh, we can use that to do this prehab program. We know that that initial referral point where the GP is writing a referral to a surgeon saying, could so-and-so have an operation, or would they benefit, are they suitable? That's the time where we've got a lot of waiting, a lot of passive time, and a lot of opportunity to actually say, yes, no, maybe, and also not just to leave people in a queue, but to say, while you're waiting, would you like to help yourself? We have 80% of people registering, and this is what it looks like. Mobile phone in the centre. On one side is an example of the exercise program, so that's just one bit of information that you may be recommended to have a look at if you say that your exercise levels and activity levels are low. On the other side of the screen, which is on your right, is the MyPrehab summary report. So after you answer all the questions, you get a summary report that says, oh, you've told us that you think you would like to optimise your general well-being, your activity levels, and perhaps your weight. And then you're encouraged to print that out and take that along to see your GP, and also to click on the topics that are relevant to you and go and have a look at those. In healthcare, we imagine everyone knows what the journey looks like, because for us it's routine, we do it all the time. But actually for each consumer, often they're only doing it the once. And so just sharing that whole journey so that people could prepare themselves is great. Some of this stuff, if we make it easier for the majority, then we have more time into care for the people who really need our help.
So since July last year, when we first rolled the program out in orthopaedics, we've now implemented it into 4 different units across 5 specialty areas at both the Royal Adelaide Hospital and Queen Elizabeth Hospitals. We've seen across all of the pathways a really high registration rate. Once they register, there's really good engagement. So 98% have completed the health screen. And this is considered a core component of the program, because following the health screen, that's when the consumer will receive the tailored information. For the information that's provided following the health screen, so as you can see, overall it's very high, and 80% are actually reviewing all of the activities they receive. And that's keeping in mind, on average, participants have about 4 modifiable risk factors. So they're not just having to click on one information topic, they might have multiple to review. There's actually been no difference between baseline demographics between our participants and our non-participants. And that includes age, gender, the need for an interpreter for health appointments, socioeconomic status, and Indigenous status. The only exception to this is that there's actually a higher proportion of consumers from rural areas who participate. So we had 133 rural consumers invited, and of which 117 have participated, with only 16 who didn't. On the index of relative socio-disadvantage, which is a scale from 1 to 10, where 1 is the lowest, the most disadvantaged, and 10 is the least, we had 40% in the lowest 3 deciles for this cohort. If we consider the bariatric cohort just briefly, they're a quite significantly disadvantaged group, and we've seen that almost half, or just over half, are in the bottom 3 deciles, and 1/3 are in that lowest decile. So in the past year, there have been 26 participants who've received their operation, whether it be for a knee or a hip replacement, of whom 20 actually entered the program when they were added to the surgical waitlist. And this was something that we implemented around September last year to try and improve access to the program to consumers. 16 of these had a total knee replacement, and the early data for the knees is promising. So you can see that the average length of stay for the Royal Adelaide PreHab and the Queen Elizabeth PreHab participants is sitting lower than the same hospital for the previous year. And it's also sitting lower than the average for our Health Roundtable equivalent peers. So that's a benchmarking group. Overall, the participants are saying that they're feeling supported, they're guided, and generally they're really appreciative of receiving this information early in their journey. There's comments such as, it actually makes one feel like you haven't been forgotten by the system.
He said he'd always wanted to give up smoking. It was the push that he needed. And I think that's my thing, being a consumer as well, is people just don't really know, that how important it is to get themselves into that optimal care.
There are lots of people involved who've really shared their time, their insights to say, actually, you're not ready yet. It also enables people to get ready, and also to pull forward the people who've ticked off all their stuff and they're doing their peri-op screening and their anaesthetic sort of risk factors. Then why don't we continue messaging them in hospital and help them get ready to go home? Why don't we have criteria-led discharge in the patient's hand about this? But, seriously, consumers are the experts in their own care. Now, we can inform and guide and provide. It's a bit like, I don't do my own financial planning. Surprise, surprise, I go to an expert. But they also ask me about my preferences, what I want to do and how I want to do it. And then they say, oh, that's not such a great idea, and we have a discussion. Why don't we apply this also to healthcare? Why do we respect everyone before they get here, and then once we get here, we put them in a white gown and they're not allowed to have a thought?
Great for rural and remote people who just can't get down here, who may have to travel many hours, potentially stay here and so forth, so the costs are great.
People on average have had fewer complications than historical controls, and we know that it is complications that lead to longer length of stay. So I think the early data are very encouraging. I think they certainly warrant us persisting with the approach.